also, if you could unmute yourselves and say your name so we can take attendance. So I'll start with me and Scharnhorst, and I'm here. Arthur,
Sampaga, present.
Julio Zamaripa, present.
and William.
Hi.
Linda Beechnor, present.
And
Gloria Fernandez, present.
Clementina Sergio-Goleb, present.
hey, Clem,
Hi.
how about the powerhouses from the center?
Laura Reichardt, present.
I think we missed
Aloha,
David.
Catherine Finn Davis, present.
I'm Carrie, I'm present. Carrie Oliveira, present.
Rian Kuwabara, present.
All right, super good.
And then we have Bonnie and Rose who just joined us. So
Oh, good.
Hey, I'm Bonnie Castengay,
Hi, Bonnie.
present. Hi.
Rose, are you online? We're roll calling.
Present.
All right. Okay, well, if anyone else comes, we'll warmly greet them and chatter at them. So thank you for coming. If you're attending remotely, which we all are, if anyone's with you in the room, tell them not to eavesdrop.
You just have to say that they're here so we can record them as guests.
Oh, yeah. So if you are alone, you don't have to say anything else. If you're with someone other than your dog, then please say so now. All right. Good then. So since this is a state agency, we have to allow for public testimony. So if at this time, I'm going to call for a public testimony. For anyone wishes who wants to, they can. For those who are in person or Zoom, raise your hand if you're going to want to make some testimony, and we'll happily call upon you. Individuals who are unable to provide testimony at this time will be allowed an opportunity to testify when specific items are called. This is hopefully a discussion. For both internet and phone access when testifying, please identify yourself and your organization, if any, that you represent. And each testifier will be limited to 5 minutes of testimony per agenda item. All written testimony submitted are public documents. Therefore, any testimony that's submitted orally in writing, electronically, or in person for use in the public meeting process is public information and will be posted on the board's website. So here's the agenda. And we're going to tee Laura right up. I hope everyone had a little chance to review that review she made, because pretty stunning.
yeah. Thank you, Anne. So on that note, I will just say that this is the fun part of my job when I get to look at the breadth and depth of the center's contribution and what the staff is doing on behalf of the state and for nurses. And I think it's really remarkable. So I just want to note that. And if Bree, can you take it off share screen? I'm not going to use a PowerPoint presentation, so we can just have so we can have a discussion here. Reviewing this document, on October 1st, when we met in person, one of the requests of the board was to understand what the center is working on and what kind of the natural priorities that have come up in our work is. It's a very hard task. That is not a small ask. And so this kind of large document is the most succinct version that I could imagine. So I hope you are able to work through it. Going through it on the furthest left-hand column, you'll see the word mandate on the top of the document. There's an advisory board just in terms of the advisory board members' functions. And then we have each of the mandates that follow. So research, quality outcomes and best practices. And then I combined the last two, recruitment and retention. One is developing strategies, and then the other one is reporting out. So functionally, they really work as one. Then the work effort topics with the status of work is that middle content with a lot of information here. I wanted to piece apart that I wanted to piece apart the status of the work and then the unmet needs. Unmet needs in no places indicate poor performance. Sometimes, and actually, I think a good example here is workforce research. We know that the research is good, high quality. We just had a little pre-conversation about that people are looking to carry to help them with their data questions, right? We know that the work is good. We also know that we had really big challenges with fielding, and we tried to get that law passed to include mandatory survey responses. And we didn't get it passed, and the Board of Nursing called immediately on the same day that that part of the measure was taken out and said, let's work together. So that's an unmet need. It does not mean there's poor performance. So I just want to really clarify that. I don't think that there is poor performance. I feel very strongly that we are a high functioning and capable team that is responding to the state's needs and to our state mandates. But we have a workforce shortage in our state. And that means everybody is looking at us for help, and we can't do it all. And so that is where I have tried to highlight what I need help with, what I know that we need the advisory board's input on, or that we have to focus our time. And administrative action doesn't mean Laura action. It means we are the administrative team. It means that that's work that we all are working on as the staff. And I think to that point, the EBP work, I think there's a lot of administrative work that the EBP team is working on to move the needle forward, to make sure that the EBP program continues to meet the state's needs and is changing as the times change. So I just want to kind of emphasize those details and help interpret that in case it was lost in my head and didn't translate. First and foremost, if we go through this document, for the advisory board, we talked at the last meeting on October 1st that really at this point in time, the mission and vision needs to be looked at again and refreshed. What we didn't do though is assign the subcommittee and start that work. So we know we need to do it, but it certainly does require advisory action and also administrative action. We need a collaborative team like we had the finance and fee subcommittee. Next, with research, the work of the supply survey, I think is very accommodating of our state's needs. We do not use the minimum data set. We use the minimum data set plus a lot of other questions that help inform what's going on in our state. Carrie added wellness questions. This is a theme that you're going to see in a lot of different spaces in this document. There's also a lot more ways to access the data than just the report. So we have the dashboard, we have infographics, we have social media, we have webinars, we have the reports, we also have the data table. So there's a lot of different ways that the data is being presented. What we need to do is work with the Board of Nursing on fielding improvements. They've identified themselves as interested and collaborative partners. We just have to work through that. We need to I also think that because of the volume of work being produced, we can add on some resources. And so one of the considerations is hiring a graphic designer so that we're not formatting our writing anymore into a presentable format, and also a technical editor, because we all really pitch in and read each other's work. But I think anyone who's read my writing knows that grammar is not my strongest suit. So I rely heavily on everybody else. We don't need to do that. We can buy those resources now that we have increased fees, and I think elevate the work and also reduce some workload from the team. With ed capacity, I really don't see there to be much need for advisory action or administrative action. I feel like it's really on course. And if we do those things that in general, getting a designer and an editor, it would just kind of help across the board. With evidence-based practice, Catherine has spent this past year really diving deep into how to continue to ensure that the evidence-based practice program is meeting the state's needs and recognizing that the state is shifting and that some of the challenges are growing and some of the opportunities to innovate are more accessible right now. So with that, I think a lot of that work that is underway should be supported. So we may require some advisory action once the EVP team gets a little bit more down the line. I think actually Thursday, Catherine, you guys have a meeting with your steering committee. So there's some work that they are going through. And I think we may come to you all and ask for some more support. But right now they're really doing a large amount of work, and it's very focused on innovation. The unmet needs, though, I just want to highlight the organizational adoption by statewide partners. There is interest, and then there's engagement. And sometimes you can have interest, but you don't have engagement. During a workforce crisis, I got an email just a couple minutes ago from the president and CEO of HAH. Highest level census of record was today across the state, the statewide census. So are we expecting perfection? No, but we know that evidence-based practice concepts and practice in it of itself would help. And so how do we kind of walk the line there? And then scalable and accessible programs. Our programs, our EBP programs, are very resource intensive, both for our staff and for the people who engage in them. So how do we engage in making evidence-based practice more scalable and more accessible? With nursing continuing professional development, we have a lot of activities in this. We moved this. We used to consider it was just APIN, just academic progression in nursing. We use that as a recruitment and retention program. But as our APIN team, we had a grant as the APIN work group kept on asking for more things and saying, well, this is what we really need. It stopped being just about academic progression in nursing and more about professional development overall. And so we moved this into our quality outcomes and best practices mandate. It was a better fit. And in doing so, it allowed for a lot more synergy within these small projects. It made more sense, but also I think we can optimize that. So one is there's a lot of work here. We have the writing workshop. We have the academic progression in nursing steering committee, which we changed to be called the Nursing Continuing Professional Development Committee. We have Success Pays, which is the certificate program in partnership with ANCC. We have academic progression in nursing. We have the Leadership in Action Conference. We have the Simulation Collaborative. We have the Continuing Nursing Education Program. That's a lot. One thing overall is I think that we can look at retiring and optimizing in some ways. We struggle to make meaningful work around academic progression in nursing at this point. Everybody says they're interested, but at the end of the day, the only thing they want is to know what percentage of BSNs we have in our state. And our workforce supply report does that. I don't think we need to ask for other people's time. And I don't think we need to pretend that that's our concerted effort. Our concerted effort is making professional development accessible for nurses, which includes academic progression in nursing, but it is not only academic progression in nursing. I think we should retire it because we're doing so many other things. I also think that in general, what I would like from you all is to look at this whole section and help think about optimizing the resources overall. A lot of the staff work on a lot of the things. Do we need more staff people? We are starting to come into the money that we got from the license fees to support that. Can we bring in someone and optimize this work so that we have, everybody works very collaboratively and they do that wonderfully. But when I look at everybody's workload, could there be more efficiencies made if we had another team member and some more organization? I also want to recognize that with that proposal, there might be warning because a lot of people love the tasks that they're working on and the programs that they support. I would really like your input on that though. I also would like to consider retiring success pays. Between 2020 and 2022, we were not able to get a cohort of 20 and we were supposed to get that annually. Obviously the pandemic and the travel restrictions had a lot of impact on that. We now have 24 people, or maybe even more today. We have 24 or more people who have agreements. So whether they take the certification exam or not, they're going to have to pay the Center for Nursing. We're going to have to make the dues, but that doesn't feel right to me as much as having 24 people actually completing the certification. So I don't want this program to be looked at successfully because it's cost neutral. I want it to really be good for nursing. It might be a better fit for us to really pursue individual organizations or maybe HHSC as a whole organization. Hey, maybe you can adopt this for your own employees instead of us, where we have less of a connection with those nurses. Just a thought. As it relates to new topics, moving into recruitment and retention as the next mandate bucket. We have a lot of pre-existing work. I didn't organize this by programs, though. I organized it by kind of topics. Wellness as a factor of recruitment and retention is a major topic right now. There's already workforce research being done. We just had a meeting. We had a 2-hour meeting a couple hours ago. Thank you, Linda, for being on 19 hours of meetings with the Center for Nursing today. The Hawaii Chief Nurse Officers have identified this as a major priority. We're working through the recommendations that the nurse staffing think tank gave us. Thank you, Rose, for sending that over to us. And then an action that we are going to need from the advisory board is to look at all of these recommendations that we've kind of edited down and gotten feedback from our CNOs and say, what is the priority for the state? What are those 1 or 2 priorities that we can do? Is wellness one of them? As it relates to challenges in recruiting nursing, there's several activities under this. So we have, we know that there's licensure delays. Carrie is working on compiling data and information that informs that conversation. HAH is interested in working on this. People are talking about the Nurse License Compact. Even though we don't have a specific work effort, we know that this is going to become increasingly important. With policy, we have that 6-month period or 5-month period from January to May is busy. And recently, there's not a break when the legislative session ends. The work to identify policy priorities, keep on working on solutions, help other nursing organizations understand what sound policy and evidence-based policy is, work with legislators to understand what's going on. So when they see a bill, they understand if it's a good or bad solution for what's going on in our state. That policy engagement piece is growing as compared to when I started at the center in 2014. This also, there could be optimization in that support as well, particularly because the work being done in what we call the interim session, which is May through December, is a lot more research about policy issues and providing information and interpreting known, known data and the environment to help inform policymakers. The nurse residency program is one of our biggest programs related to recruitment and retention, and it's grown sizably since the start of the pandemic. We also know that long-term care needs residency and that there's not necessarily the staff. We've been looking for grants so we can get a nurse educator, like a statewide nurse educator, to help with long-term care. We're working with HealthStream to customize curriculum and make it shorter, like a 6-month residency instead of a year-long residency, but it also requires more human resources. It's becoming more laborious, particularly with having the grants, it's becoming more laborious to manage that. And then the clinical placement collaborative, as it stands, COVID has complicated things. And then our partners have recognized that it's actually quite time efficient for them, both on the academic and the practice side. And they're asking for the Center for Nursing to manage all clinical placements for all health professions, essentially. So that is particularly the case for our community colleges, which have more health education programs. But the way we fund Hawaii Clinical Placement Collaborative is through partner contributions for nursing. And that supports about 60% of Bree's time. What would happen if we took on all of those other professions is that we would max out our human resource bandwidth immediately. We'd max out Bree's time. She's also working on NRP. To bring on allied health requires additional staff. We can do that through partner contributions. We also were trying to get a grant with the Workforce Development Council, but they did not have the funds available that they initially thought they did. It's becoming increasingly important for our healthcare providers to have this resource. And every 2 months they ask for it, and then we just are not able to launch it because they get pulled away from an initiative and we're not able to meet with them. So it's a priority, or it's an urgency, but not a priority, if that makes sense. And I think having additional staff would help, because some of the work that keeps on getting put off would have dedicated, committed time to it. For us and also for them. Preceptor shortages continue to be a challenge. We are increasingly short of preceptors, despite some good efforts to further support and develop them. The Board of Nursing recognizes preceptor time as part of the continuing competency requirements. We have the preceptor tax credit, a program which we run to support APRN, preceptors of APRN. So physicians, pharmacists, and APRNs can get the credit. We also have training through HealthStream for the nurse residency program, but we are still short. And so we need a strategy, and we also need prioritization of preceptor development, if that's a priority, right? It's like, which of the many things on this laundry list here? And then simulation capacity. During the pandemic, the simulation work group asked the Center for Nursing to start coordinating their working group. That's up in the nursing professional development section. But we also know that the physical constraints of the simulation centers are inhibiting progress. They're a bottleneck right now. We don't use 10-year-old phones. They can't use 10-year-old mannequins. So we need to find funding for new mannequins and also for school staff and healthcare facility staff. It is a specialty. So you have to have those people who have the specialty. Otherwise, you're not really taking advantage of the resource and the opportunity. Again, that's a choice. How or when or in what ways would we prioritize? There are a lot of work efforts underway. Every time I come across an opportunity to spend money, I ask for the simulation. So we may be able to have that resolved by May. We may not, though. The APRN access to care, the unmet needs, there is a working group, and they've been working since 2009, or actually I think about 2013, to address APRN barriers to practice. This is one of the policy initiatives that I mentioned. The legislature has essentially asked for a scoping review of the state laws as to which laws should APRNs and other professions have, be included in but aren't. And they have a poor understanding about the difference between scope expansion and aligning laws to meet established scope. That's a big challenge. And this work group right now is all voluntary except for Amy, Ono, and I. And so there's also this opportunity to support that work through administrative resources, staff. So that's looking at the policy. This is a very big undertaking, and it's always being put on back on the boilerplate because there are more priorities. That's a lot, and it's really hard to synthesize, and I didn't want to create a PowerPoint presentation because I don't think it would have provided any value to anybody. But what I'm hoping is that this can be combed through. I highlighted the areas where I consider a need for advisory action. And I also noted the areas where we're already working on we're already working or know that we need to work on these, certain areas. Where there is no work or intervention needed, I mentioned it's no action needed or maintain course. We don't, if it's not broke, don't fix it. And so I did try to put in that kind of guidance because I know that it is so much. But at the same time, we just can't do it all. And even with the increase in funds that we are starting to see, we also know that the whole nation and world is workforce short. And so we can't buy our way out of this challenge of having so many interests, because we know that there's likely not going to be enough people that would actually join our team. Everybody's looking for staff right now. So I don't, and we have to be scalable and bring it, if we were to bring on an imaginary number here, but if we were to bring on 6 staff, I don't know if we would scale in a way that would maintain quality. I'm interested in maintaining quality because I want us to move the needle. I want us to have impact. I want us to meaningfully provide for our state. And so we can't do it all. I was so happy that Sherry Daniels' presentation really focused on, you don't need to have long 5-year strategies with 8 end goals. You can have 1 or 2, and you can do short 6-month, 1 year, 2-year goals, and that's okay. And that's great. So I really want to embolden you all with that, because the more than any other time, I think, in the Center for Nursing's history, this workforce crisis is so large and so different than other workforce shortages and crises. And so we need our advisory board's insight and input more than ever. So thank you for being here with us today.
Well, it's an amazing body of work. I always imagine an infographic, but it's too big, I think. You have to do an infographic on every one. But you guys yourself, I just want to thank you on behalf of us all for not just your huge hard work, but you're such experts in what you do. And it's really impressive. So us as the board, you've pulled together a lot of different people. We have a variety of roles that we come from. So we do have a variety of perspectives, in this advisory role. And I like you harkening back to Sherry Daniels, because I feel the efficacy of that strategy of just picking, 1 or 2 or 3 things and putting all the power on it. And, investing a lot of effort and brains into it and really moving it forward. So, I mean, you just the things that you wrote on that said the advisory board could help is 9 things. So I'll just say that it's high level ones, but I think the issue for our point of view, from the board's point of view, I like to think about it from how do you feel and what are your passions from where you are sitting in your desk every day, what is moving you? And that might be ways we can align ourselves with the staff and the initiative to really help push things forward. So, she talked about mission and vision. That's kind of the philosopher's job. If that's you, you go, and the EVP, I have never heard it quite said like that, Laura, but how you focus it in a different way. Opportunities have changed. It's not just teaching the process. It's really finding how to apply it in these new problems with recruitment and retention and wellness. We have to use the process against our problems. And then all that, I love the idea, anything that you can sunset, I think gives you a breathing room. But that whole CE thing. So I mean, wellness, recruitment, CCPS for everybody else got to pay for it. The faculty shortage is obviously near to my heart, and the preceptor shortage is not much farther away from that. And I like too, the distinction of the barriers to practice is not so much what they can or cannot do, but how the laws support them in doing what they're allowed to do. So I don't know, what do you guys think? Oh, and one other thing I think of, all this money came, and I heard you say 3 or 4 or 5 times, we could hire somebody for this, but there is a budget need. You need some budget brains too. Like, how do you look at it? If you get, 250 grand, you could do a lot of different things with it. And how, if we can pick those 2 or 3 things to start with, how do you really apply the budget strategically? So
And
go ahead.
If I can just interject with the budget. And if you look at your notes or your board packet from October 1st, you'll see some budget projections. There will be money. We have the money now. So it's not, do we have the money for staff? That job was accomplished. The Finance and Fees Committee, the bill that got us here, which is not saying we don't have money for staff. How many people can take on another duty? We have the money for the staff, guaranteed. So knowing that there is an option, but it's probably not the right thing to hire, 4 or 5 people. How do we optimize the staff to also optimize the outcomes here with these priorities?
Yeah, so I'm just wondering, like, as board members, where do you, after listening to all this, is there a place in this milieu where you really feel some passion, where you see, thinking in the Sherry Daniels kind of way, I can just really afford to put some time into 1 or 2 things and really help move the needle? What kind of this whole big thing are you thinking of, or is any of this moving you? So go for it.
Well, the workforce shortage, of course, is very, very, it affects everyone. So, that's maybe a priority we want to put our arms around. And then also recruitment. Teachers, professors, we need to continue on those things. And then, of course, on the practice level, preceptorship. So those are things that hit me.
One other little kind of cousin of recruitment is retention.
That's true too. That's very true too. So,
And
but there's
it might find some of its solution in wellness.
That's right. But I agree. I think and I think that's why we asked this is, could we prioritize 2 or 3 priorities for the year and put our efforts into it? And where we could help as board members, we're happy to. Or where we could recruit other people, or who we could partner with other organizations to get this moving, because I think we do so much. And it's not to say that other things are let go. It's just that, you know, the main emphasis and the power of people are placed on the priorities.
Hi, this is Rose. I mean, I echo what you said, Bonnie, because looking at it, I kind of feel like you got to look at the Maslow's hierarchy. What do you need?
Yeah.
And you can't get to the higher level thinking anything without staffing. I could tell you, like, internally here, we are struggling with staffing, and I feel like that's pretty much kind of what's happening all throughout. When I look at it from our system level, every day we're short and we have more patient, we don't have enough capacity. And that's why people are getting burnt out. So they could do their job well, but you know, it's really staffing, and we don't have enough staffing. You can't have meetings to do evidence-based practice. You can't do, you know, other things. And nurses are feeling bad because they feel like they're not providing quality care. So it kind of goes back to like, what is the fundamentals and what is, you know, the basic needs first. And if I was to rank it from basic needs, then it's really staffing. But at the same time, we are working with a very different healthcare environment, dynamics, and changing consumers, right? Like, and generations of both our workforce and the consumers. And have to really be thinking more innovative way and not the status quo of how we operate what we normally do.
Right.
So I would challenge all of us to be really thinking, like blowing everything up and just say, how do we create it with a different model?
Hi, this is Arthur. You know, Laura, a lot of work, and I look at it as triage. You know, let's just triage the work here, because seems like everybody's overwhelmed, especially the center. What you mentioned, retiring, couple of them, and I totally agree. And I'll just give examples. So, like the academic progression in nursing, I think we're at the best we're going to get. You know, I'll use my hospital as an example. So we're climbing BSNs, and now you have a nursing shortage. We hired all the ADNs from the school, from the community college. So that kind of set us back. And, you know, it's an uphill battle, but I think we're going to have to stop it at the moment. I mean, and you've been doing this one from the beginning of time, I believe, right? This is like one of the first initiatives. And then the second one, Laura, I think retiring the success pays. You know, now this is a different. I just found this out that a lot of my nurses are getting certified in the comforts of their own home. They have a proctor. They just log on the computer and they do it at their own time. So all our prep courses, all our all our group work to try and get them certified has kind of stopped. Everybody's doing individual certification now. So I think we have hit a roadblock with the success pays. So those are my two. Again, if we was to triage it, that we would have to probably retire those.
Yeah, thank you, Arthur. Particularly with success pays, we'll see a lot of people interested. And then, so they'll register with us, but then when we get the MOU, kind of lost to follow up. Even with the MOU, you know, we have over 24 people registered, only 3 people or 4 people have signed up. So I think it was a good idea. We tested it. Maybe didn't pass the pilot phase. Linda, you on mic or unmuted?
Thank you. Anne was asking which one jumps out at us as a priority, and it's number 5 for me, the wellness as a factor for recruitment and retention. I agree that we need to be looking at the root causes for our staffing issues right now. And in general, I think that our nursing community is demoralized and needs to know that the community has their back. And wellness, getting back a feeling of not only personal wellness, but that our healthcare system is there to support nurses in times of crisis, and that the community is there. I was saying in the last meeting, this started on a downhill crunch because in my mind, the community let us down in the beginning of the COVID crisis, in that we didn't have what we needed to protect ourselves and our families. And I think that needs resolving in order for nurses to come out of this crisis that we're in. And it was suggested earlier today that there needs to be a campaign to bring the joy back into nursing and the things that we came into nursing for, to remind us of those things, and that the community is with us. So I'm really devoted to wellness as a factor for recruitment and retention.
So I would agree with Linda that in terms of priority, as it relates to our workforce, definitely workforce shortage is a big issue, but moreover, wellness, retention, recruitment and retention is very important. If we address that, I think the others will come through. So I was listening to, I've been reading a lot, and have heard that within 1 to 2 years, upon entering the nursing workforce, nurses are leaving the profession. We can keep producing from academia, but if we're not retaining, it's like you have this open faucet that just keeps running through. We'll never meet the nursing shortage, right? So wellness, resilience, retention, those are important issues, I think, for us to really pay attention to.
And in some ways, I think, if you don't mind, if I add, but
go ahead.
When we have that open faucet, as you described it, what happens is we just keep on turning up the volume of the water. And where is the source of the water? The nursing schools. But there's a capacity there. And so it's like, are we able to refill the basin only from the spigot? No, like there's capacity there. And the drain is happening faster than we can refill in that way. So I think those unintended consequences of then putting pressure further and further down the line is really challenging. And if we could shift some of that effort or energy, it would be I think, gosh, what an optimal outcome.
And you know that losing tenured, seasoned nurses is devastating. Whether we could replace them one by one after the other, they're not the same. A new nurse is not the same as them. So the retention, is the plug in the drain, in the basin.
And one thing I just want to add is we talk about wellness so much in our world, but I'm wondering if it's a wellness environment, because I feel like we're kind of like, you got to be well, you got to self-care. Like we're putting it back onto each individual versus really correcting the true source, which is all that plus we don't have a healthy environment that is supporting that. So, I just don't want it to be where we put it back onto the nurse, like you got to take care of yourself. Yes. Right. And we need to provide you with a healthy environment too, that
Right.
supports that.
Good, good.
Yeah.
So it's a culture, the organizational culture. Yeah,
And it's a struggle.
yeah, that's huge. But it's a good point. Very good point.
Great point, Rose. Thanks.
And I just want to throw out one question, like, are there other groups already focusing on any of this initiative where we could say, you know what, they'll focus on it, so we could peel off a little bit? Like, you know, like, I love the leadership topic. That's why I'm like, oh, leadership and action conference, being involved in influencing that. But is it okay that we trust the other organizations to continue to lead that? So then we could concentrate on other things. So that's some things that I'm not sure of what's the, you know, who's leading what.
Mhm.
Yeah, I think certainly, I think leadership in action would be very sad to lose Leanne's program and planning. She does a lot of work for it. But could it be, you know, was there a time when we were not involved? Yes. Could we stop being involved? Yes. Some of the contributions, Leanne does the awards, the travel, all of the programs I support with sponsorship. And then we also always bring in a national speaker that I think comes from a different perspective, because we have such a different, we are exposed to different people than AONL and ACAG. So that's what we bring, but we don't have to be. Conference event planning is very labor intensive. I think research, I don't think there's really anything that could be peeled off. We don't do projections. In the future, if our state needed projections, Carrie has done kind of the cost analysis and feasibility analysis to figure out how to do that. And that would be something we would purchase. That would be a contract. And we don't do workforce demand. HAH does that. With quality outcomes and best practices, I think we talked about what we could peel back from nursing, continuing professional development. Catherine, I don't know if you want to comment on EBP, if there's anything. I think you're really working on resource optimization. So I don't know if you want to provide anything to the board provide some sneak peek.
Right. Yeah, I think we're already in the process of streamlining, hopefully, with the, kind of retool over this past year, because I think we realized what we were doing is great, but it's not very efficient. And trying to kind of, take a step backwards and look and get feedback from the community that we serve and see how we can, I hate this, work smarter, but not harder. Right. So I think that's where Leanne and I are with the EBP programs. And we try to meet the needs of the community. So what we're hearing you guys say you want and need, that's what we want to provide. So I think we're already kind of doing the process. So I think we're good.
Yeah. And I'll just highlight what they're looking at a online repository that would make the EBP work in the state more accessible amongst colleagues in a confined and controlled way. I mean, it's not a free-for-all access. And also, Catherine's done a lot more collaborating with national leaders. So she's not developing all the training herself, which I think has been a big shift. With recruitment and retention, the wellness topics are taking on a lot of time right now. I think they've increased. I mean, the requests consistently are very, very concerted. The CNOs have said we need to work on this. Whenever the numbers come down or a crisis comes down, the first thing they start talking about is wellness. Licensure delays, we're not really working on it in a strategic way. It's kind of, it keeps on coming up, but it's not well organized. I'm trying to think of other things that could pull off. I think with these sections, it's really about how you can add on to make the staff time more efficient and effective instead of peeling back. So I don't think we can stop doing clinical placements or stop doing the residency programs, for instance. But with the volume increases that are being demanded, there's a better way to do that work. And then with the APR and access to care, there are not any other people who are, there are a lot of people who are working on it, but I think that we're shoulder to shoulder. I don't think that there's necessarily a single leader. And so I think if we were to pull back because we're shoulder to shoulder, I don't know if there would be progress. And I think that that would become an unmet need that becomes entirely unresolved.
And I don't know how many people are shoulder to shoulder with you in your knowledge and use of policy. So they might be great partners in, you know, framing and needs and strategies, but getting the policy through is really a strength of yours.
Yeah, thank you. And
Yeah,
I'll just mention, it's the Board of Nursing and Happen really that are strong partners in that, which then you have the regulatory and the practice. So there's a nice triangulation of skills.
So when you say that there's shoulder to shoulder in regards to the APRN legislation portion, and that if we were to pull back, you are stating that we feel like that we would lose progress there. Is that correct? Is that what I heard?
Yeah, let's imagine this like a very heavy boulder that you're pushing up a hill.
No, that's fair.
Yeah.
Because I was gonna, you know, when I was listening to everyone else and chiming in, and I was like, you know, I was gonna say that is probably more dear and near to me as far as APR and access to care, because, you know, we talk about workforce shortage. We do have a lot of APRNs that are graduating from our programs, yet are we utilizing them to the full capacity in our region to where we should be? And I can see you shaking your head no, it's no, and I can see it myself. And we really need to leverage that, because in all reality, when we're doing recruitment, I see it from the physician recruitment side, it is not easy to find some of these specialists or providers. And if we can leverage our APRNs with the current physician staff that we do have, we would be in a better place, making sure that they have the full rights and privileges to go ahead and take care of our community. Because again, at some point in time, we are really like a rural area. And I'm not even talking about Oahu. And so you're like, what? You can say that on Oahu. What are you talking about on, you know, Big Island, Kauai, you know, Molokai? I'm like, hey, I get it. But we're having those challenges just in regards to staffing. But we want to make sure that, you know, we're producing our APRNs. So yes, another thing that I would say is the recruitment and retention of nursing faculty is super, super important, because we still need to generate these APRNs, but also just registered nurses in general. But again, we need to make sure that when they are graduating, that we are, you know, investing in them to where they are working at the top of their license to provide the care that we need within the community here. So I would like that to maintain a priority for the board.
Okay.
And they gotta stay here too, once they're made. People are
Absolutely
offering them sign-on bonuses and let a residency in any unit of specialty that they want. So everyone's is headhunting new nurses, including out here.
Yeah. Well, if I can just list off where my notes are, would that help you, Anne? All right, so these are just I was just like writing the main words and not the discussion. There's workforce shortage, recruitment, and retention, and wellness, practice, preceptors, Maslow's hierarchy, with number one being staffing. If we're going to triage, what can we retire? APIN and success pays was mentioned. Wellness as a factor of recruitment and retention, addressing the demoralization within the nursing workforce. again, focusing on wellness, recruitment and retention, but really honing in on the retention problem as an open faucet. And as the, and retention also being the plug in the basin. Recognizing that we don't have a healthy environment and we can't put the responsibility on the nurse to be healthy, or to feel well, that it's the environmental responsibility. Asking what else can we peel back, mentioning leadership in action, and then circling back again then to nursing faculty and APRNs. I probably missed some things.
You know, if we had one of those things where you put a little sticky note under, you know, and gather all the things that
To vote.
are,
Word
you know,
cloud.
yeah, or
Yeah.
that are kind of the same. You know, we're approaching the same priorities, but from different levels. So it really sounds like I think, you know, recruitment and retention and wellness are really like a braid. You know, they all had, and a lot of the things we're talking about are permutations that spin off of that. So, and I really like that idea about Maslow's hierarchy. If we don't have nurses, enough nurses to work, the ones who are working are suffering. The hospital's suffering, and they get more cutthroat with their budgets and every other stupid thing they do because they're under crisis. So that doesn't make the environment well. So I think it really sounds like the priorities from us comes with, you know, the recruitment, the retention, and the wellness, and all the things that swirl around it. Is that how you guys are hearing it?
Agree.
Yes.
I mean, it's only 2 or 3, but they're only as big as Mount Everest.
They are.
Or bigger.
Mm.
But what's the start? So the question is, I think everyone agrees on that. What can we do ourselves, this group? Where can we throw our shoulder into these efforts? Now, I know for sure you asked Laura for a working group for mission and vision, and that's a nice, easy one that'll have quick satisfaction. But maybe, you know, we could align ourselves along some of those work groups that you have, Laura. And, you know, and could we help, you know, Bree figure out how to expand CCPS for allied health or something like that. But if we really throw our shoulder into something that's very actionable from your point of view, I think will be helpful. Our hearts are sure there, but I think we all want us not bemoan, but innovate. And some of it'll just be a little effort. So I kind of will throw it back to you and say, we really want to jump on board. I would love some practical measures to, you know, do we need to send you takeout food on Fridays or, you know, something in that's funny, I know, but you know what I mean. I'm trying to be practical too.
Well, I think before I respond, I saw Gloria videoed herself for a moment. I don't know if you were going to chime in for anything.
You know, I'm listening to the conversation and stuff and trying to figure out, because, you know, we're, you know, public health, population health, we're really out in these communities, having the one-on-one once they're discharged from hospitals. We're in the communities helping them to figure out where's their closest services, how can we get them there, how do we get them to people to take advantage of it also. But when I listen to, you know, for lack of better words, eating the young and things like that, I know when I first started nursing, I was lucky enough to have a preceptor that, and I guess it's kind of out of the box thinking on what can be done, And I was reminded over and over and over from my preceptor, you have learned so many things in nursing school that I did not learn when I was going to nursing school. And it created, I guess, not necessarily a gap in, well, you could say a gap in knowledge as to what was being taught 15 years ago as it is being taught today, and what will be taught 5 years from now, to where senior nurses now begin to feel maybe, wow, I didn't learn what's new. How do I understand this situation and be able to be comfortable in, I guess, two-way learning and teaching from our new graduates that come in, that they're bringing in the most current knowledge from nursing schools and what they've learned. And that is something that, as a more seasoned or senior nurse, maybe the academic side to this might be something that might be helpful to connect the dots to why the new nurse behaves this way or performs this way, rather than kind of getting upset that they're not necessarily doing it the way that I did it, kind of thing. And so I was just thinking about, wouldn't it be great if there were opportunities for senior nurses who have been out of academics for quite some time, the 15, 20 years, where there's something there for them to understand what the new nurses are learning, to be able to understand how it fits into healthcare now in the nursing field. Just kind of throwing it out there.
And that affects the preceptor discussion for sure.
Mhm. It affects the retention too. I mean, we've said that there's such a big cost of losing an experienced nurse. But also we lose so many nurses earlier in their career. So there's definitely dissonance there, right?
I also feel like if you're precepting, it's not because you hate nursing. So there's still like love there, right, for the job. And I feel like there's an opportunity for a preceptor to talk to a new grad who's at risk for being like, nope, I'm out, to talk about what is it about that has caused them to love the profession for as long as they have. So I think there's a retention opportunity there too.
And that kind of reminds me of Linda said, and even Rose too, you alluded to it, the environment is not healthy. And the nurses don't trust the environment. The dog is turned around and bit them. They don't trust that. And how that recruitment, that retention, that wellness of the environment, that makes it the place you want to be, that you're willing to commit towards. That's at the bottom of a couple of big things. And even like you said, Laura, that's what the CNOs are crying for. How can I make this environment not so stressful and so toxic to work in? Because people care, they really know. So it might reside in, the epicenter might reside in-house. How do you make that house more livable? And once nurses felt that, I think they'd have, the hope again and be back. Like Carrie said, I still like it. I think you should stay. This is worth it. The impact we have, and my organization acknowledges and knows what I do.
And I do see that it is a way of bridging the generations in nursing, on bringing it together on new graduates, because we have, I think in all of our facilities, we have those nurses that are really open to learning from the new students. I didn't learn that. Can you show me or explain to me? But you also have those that are, no, you're gonna do it this way because this is how I learned it. So this is how I'm gonna teach it to you. And I think there's room for both. I really do. But what environment do we need to set up so that both can come to the table and be willing to share openly and learn from each other that way? I mean, in public health nursing, we have some nurses that are really great at sharing and learning. And then we have others that are just like, I have to remind them, stop eating the young, teach, model, coach, rather than gobble. And so, you know, I know it's frustrating. I see the faces on some of the senior nurses, like, this is not how we do it. And I get it. But I also see the faces of the new nurses who have so much to learn, but also so much to teach when they come in. You know, and they're the ones that are showing us what the new nursing is about.
I
And
like
that's a
that.
healthy environment too.
Yeah, I think it's such a wealth-based perspective. You know, instead of talking about new grads as a liability,
Hmm.
which is so often. I can't tell you how many times I've heard people, including nurses, say, I can't afford to hire a new grad. And they're talking about the cost, the time, the productivity. But Gloria, you're offering you're flipping it and you're saying you're using a wealth-based, a resource-rich based perspective to find ourselves out of this workforce shortage.
And I'd like to chime in as well. I think we've talked about maybe joint appointment, right? Where we have, you know, maybe nurses who from the practice arena would teach in our programs instead of leaving the profession, because they have a wealth of knowledge to pass on to the next generation of nurses who will provide care for the future. I mean, that's something also that shows value, you know, for both, right? But I mean, you know, how do we make the environment well? I think this is where research comes in. And perhaps we could do focus groups in each of the hospitals and ask, you know, how can we make this place a place where you want to come to work, right? That, you know, when you enjoy your work, you enjoy where you work. When you enjoy your work, I mean, work is not work. It's like play, right? I mean, and I refer that to myself because I mean, I work very hard in what I do, but I enjoy it. So to me, it's not work, right? So how can we make the environment so that it's joyful for the nurses? So I think we need to talk to the nurses, right?
If I could jump on to what Clem is saying, I feel like too, there's this phenomenon, right, where we experience something and then it becomes true, even when the world changes around us. So I think that it is probably the case that a lot of nurses were treated badly or felt frustrated during the pandemic, but every employer that I know of is working actively at measuring and implementing programs to support the well-being of their nurses. And there doesn't seem to yet be a correspondence between the employer's activities and the perception of the nurses that activity is going on. So I feel like there's if we start talking to the nurses and being like, hey, yo, what do you need? And they say, oh, I need a care cart where you come around with aromatherapy and gummy bears. And like, actually, that totally happened on Tuesday on your unit. How did you miss it? Then we start figuring out there's a perception issue instead of an actual environmental issue. And sometimes all you need is that, like, oh, there's gummy bears. Okay, I'm cool now. So I feel like that's something that we need to investigate as well.
And I do know there is evidence-based standards for healthy work environment, and there's 6 components. Like one is appropriate staffing. Another one is meaningful recognition, authentic leadership, effective decision-making, true collaboration, and skilled communication. It's like all those components, but that's where I feel like that's where the leadership really needs the support, because I could see them, they're just squeezed so tight that it's hard to handle sometimes. And I think it's because they're fighting appropriate staffing. Like, you gotta drop everything. I don't know. I don't have any answers. I'm just really puzzled.
Well, you might not be able to do all 6 things at once, but you could do one thing that you feel like you're the nearest to. And improve, or your institution is the nearest to. It might not be a cookie cutter. It might be a little different for Maui or for Hilo than for Queens. But to be like the same concept of not choosing everything, but choosing just 1 or 2 things and really pushing on it. And then that's a demonstration project, you know, it's a demonstration to the whole organization that, look, we can actually affect things for our better.
And perhaps even a dialogue between the leadership and the staff themselves, right? I remember in 2001 when there was a strike, and there was one organization that did not, that was Kaiser, because Bruce Benke, the CEO of the hospital, actually spoke to the nurses and said, look, this is what we have. I know what you're asking for is this, but we really don't have the capacity, or this we can give you, this we cannot. And he was just very honest with them, and they didn't strike. All the other hospitals did. But he spoke to them and addressed their needs and say, okay, I can do this, we can do that. But if you go on strike, it's going to really devastate us as well, right? So I mean, perhaps even a dialogue between, you know, the leadership and the staff themselves. I mean, if there needs to be like a forgiveness type of thing, like, I'm sorry that this happened to you. This is that this happened during the COVID. We can't turn, I mean, but this is also the challenge, right? That we had to put, that we had to contend with as your leaders. Perhaps explain what they had to deal with on their end that made them act the way they did, right? And apologize if maybe that would help, right?
A nurse emailed Hilton today. He sent it to me. He didn't include the person's name, but he said, the nurse was like, you know, I've worked through strikes before. Speaking of strikes, we know that there's one on the docket. And the nurse said, could the whole community get together? Because we know that when there's a strike, the patients are going to move around. Could we have like, and I had to, essentially what they asked for was like rolling diverts so that each hospital would have a period of time where they had kind of moderate patients, patient census, so they could get a break, and then it moves around so that all of the other nurses in the community were taking on the added responsibility for the nurses who are striking, but also getting a break so that they're not carrying the full load full time. And that was really interested, talking about nurses, you know, hearing from nurses what they need. And also, Clem, talking your example of having this frank discussion about, you know, this is what you're asking for, this is what I can and can't do. If that's representative, and who knows if it is one nurse, one email, who's compelled to write. But that message is not, I'm ready to quit. It's, I need a little bit of a break so that I can continue. There's perseverance and commitment in that message. And that was, you know, like, that's really a powerful statement. Not frustration, not anger, not, you know, lack of understanding, saying we got to support them, but we need a little bit of support too. I think there's a way that we can have both.
That could have application outside of a striking scenario.
Right. We're having record-breaking census.
Right before the strike.
Before the strike. But how do we give a little bit of reprieve so that people can persevere?
And one of the things that was really resonating with me when I went to the Magnet conference, where there were speakers who were talking about, are we measuring the value of the nurse? We're going to always have staffing problems until the way we get reimbursed changes, right? So like, what is the value of the nurse and how do we, it really hit me like, I don't know if we're going to fix everything until we are able to show that value for the nurse. And the other thing that always resonated with me is you can't get to wellness unless you bring healing. And, you know, the healing starts first, and that's a space where people could just share their stories. And people don't want a solution. They just want authentic, deep listening so that they could find that healing to move into wellness mode. So, you know, not to just jump into, you know, what we think is right, but what are the necessary steps?
Yeah, that's awesome. You can't really start exercising if you have a broken leg and every time you step down, it hurts.
Laura, can I add something? I'm part of the CNO work group, and we meet every couple of weeks. A lot of knowledgeable people, frontline leaders there. But is we do share. We share our current status, the situational reporting. But there's a piece where I think we can take it to the next level, and we can share what we implement to make it a better work environment. I think every CNO's got a little trick up their sleeves. Most of them just holding it for themselves and they're not sharing. I'm open to share everything that works. But I think it's like the CNO work group is a good place to start.
You should share what doesn't work too. It saves people time.
Oh yeah, of course.
Kind of apropos, Arthur, I mean, the CNO work group is really who brought this topic up. I mean, Carrie already had started the research, but the urgency, I think, was with the CNOs.
Yeah. But you know, we just share our status. I mean, we know we have COVID patients. We know we got 40 patients being held in the ED. We know we're short staffed. I mean, that's a given. Let's take it to the next level. What are we doing short term and long term to fix it?
So Laura, do you want a list or?
I would like a list.
You like a bulleted list?
I would like a list. I think, you know, I didn't have any expectation that the answer would happen today. You know, we do need to have our mission and vision work group. I don't know if the board would like to form another work group to further define the wellness, recruitment, and retention efforts. We do have a working group already, a wellness, recruitment, and retention. We met earlier today. Where we're working through identifying the nurse staffing think tank recommendations. We peeled back all the things that are just organizational and are focusing on what's statewide, and we're going to bring it to you all. But our next meeting is in January. And I think there is work that can be done between now and January. I don't, you know, that almost feels 6 weeks, almost feels too long for me to re-engage with you all on this. So it would be nice to have more communication in that time period than reserving any feedback or response, you know.
Could a board member or 2 or 3 join that recruitment group?
Mm-hmm. Yeah, we have Linda on it and we have Roberta on it. We are very much able to bring on more people. I think, I don't know, Carrie or Bree, the sunshine laws, I think as long as it is not decision-making anybody can meet because it's a working group. It does not, it wouldn't become subject to sunshine law acts, but we can post those meetings if
Well,
we
it's
were.
not, it's not a meeting of the board, right?
It's not a meeting of the board.
Yeah, well,
working
it's,
group.
the sunshine laws are very particular that it can't be a discussion of board business.
Oh, then yeah, that wouldn't, it
So
wouldn't.
if you're talking about committee work that's addressing other topics, then it should be fine. It's not subject to sunshine laws. Anything more than 2 people talking about anything that was related to board business is prohibited.
And it wouldn't be that.
No, unless you're making a formal document that states for the board, then you should be fine.
Yeah, no, then does not apply. Thank you for working through the laws and rules.
Oh, it's been a kerfuffle. Speaking of laws, you don't forget to make the announcements about the
Oh, yeah.
ethics.
So I guess before we move on to announcements, because we just have a couple more minutes, it would be nice if people want to volunteer for the mission and vision, which should be short. I think Catherine actually drafted everything that she thought she envisioned on October 1st. So it would be nice to have some volunteers for that, which would be quick work. And then it would also be nice if people do want to join the wellness recruitment retention work group to know who those people are.
Any volunteers? I volunteer for everything, so I'm gonna be last. All right, Arthur, which one you like?
For the mission.
I like the
mission.
wellness. Yeah.
I've been with I've attended a few of the wellness, so I can go back to
Yeah.
that.
I would be interested in the wellness.
Okay.
Arthur, which one?
I'll do both if they don't
Okay.
conflict each other.
I can do both too, Gloria.
Okay.
All right, so for mission, you got Julio, Gloria, and Arthur. And for wellness, you got Clem, Bonnie, and Gloria, and Arthur. Plus, you already have Linda and Roberta, right? But this is in that mire are really the deepest issues. So just more discussion to try to find the end of that ball of spaghetti where we can try to, pull out the 1 or 2 things to really work on.
And then Catherine, you're still team mission? She's muted herself.
I'm supporting both efforts. Bree.
Ooh, her mute's not working, Catherine. Oh, she ran away. I want nothing to do with the mission and vision committee.
Oh, that's okay, Carrie. I can pick that up.
I'm just
Carrie,
going to
you're
be
on
there for
phone.
documenting.
Okay, so we got those 2, and
Awesome.
then, so if you when you lay your head on your pillow, if you suddenly get a lightning bolt, make sure you write it down and pass it along. And between now and next January, we wish we, had something we could all work together on.
Great. Thank you so much for everybody's commitment for additional time to advise us and participate in our work. I really appreciate that. Okay, we have some announcements. Thank you, Anne, for highlighting this. We now have mandatory ethics training. There is an online self-directed training that takes approximately 30 minutes. And Bree has the resources. HSCN advisory board members are not required to complete the self-directed state ethics training. However, it is highly recommended. Yeah. I have to say, I did the in-person training. It was really nice. It was just like affirming. So it was not painful, and actually it was nice. So I just want to convey that.
I did the online, but I'm required to do it, but I thought we were all required to do it.
No,
If you were appointed as a governor appointed on a governor appointed board. I mean, they're not gonna audit us, I'm sure, but I thought that was the requirement.
if you, well, there is an exception to that rule. So if you're on a governor appointed board that is only in an advisory capacity, so there's a specific clause, and given that we are an advisory board, we fit under that clause. So lucky us, you're not required or mandated to do it by law. But again, it is very good training. It's good to know what's happening in the environment. It only takes 30 minutes of your time. You can do it anytime you have the opportunity. So I definitely would highly recommend it. And normally when we do our board onboarding, we've also included this as a recommendation in that training session.
And then our
Can I
next,
ask where we can access that?
Yes, in your packets, under the Act 165 requirements overview on the slide, there should be active links to an overview for the flyer, which kind of explains the new laws. Also, the self-directed online training. So that's the actual active training. And then there's also a handbook that's got a lot of really good information for state boards and commissions.
Thank you.
and then we did talk a little bit today about the Leadership in Action Conference. The awards are, the nominations for awards are live right now. There's Dwayne D. Walker Nurse Mentor Award, Emerging Leader Award, Emerging Nurse Award, and Nurse Advocate, which is a non-nurse who advocates on behalf of nurses. Nominating people is one of the best jobs of being in a leadership board, getting to recognize and celebrate others. So please do think about the people in your circles and nominate them. And then also all of the advisory board members are considered, would get the member rate for this conference. So we also have that benefit of being co-planners. It's on, the conference is on October 23rd and 24th. Nope, it's on February 23rd and 24th.
Not October.
Not
Yeah.
October.
February.
That's a long time from
Definitely
now.
February.
You know what? I should never say month names because I always get them wrong. Do we have any other announcements? I think that's it.
I just dropped in the chat that HH's Health Workforce Initiative report was released earlier this afternoon. It's what we call the HH Demand Survey. So that's available. I dropped the link in the chat. It's depressing. So
Yeah, it's very depressing.
Oh, it went live today. I thought it was going live on Friday.
Yeah,
I thought so too. I was surprised when it came out today.
I'm so excited to get into the data and compare it to our most recent investigations. So,
999 RN openings
mhm.
statewide, which is like, I don't know, remember what the percentage increase over 2019 was. So it's depressing.
That's a doubling of nursing by specialty.
Yeah, it's something like that.
Laura, what was the census today?
Oh, let me pull up that email and I can tell you right quick.
Just wondering.
So are we going to meet in person? Just throwing that out there.
Wait, how did you do that? Oh, it's just...
Sorry, everyone. I was just trying to grab your attention.
That
I
works.
see you, Bree. I see you, Bree.
Our census today, excluding healthy newborns, was 2,554. We have had 11 days over 2,500 since August 2022, including 5 in the last 7 days. And we have a higher, our census, our census is higher than the peak total census during both Omicron and Delta surges.
Wow.
Our most recent 7-day average was 2,512. And actually, to that point, I invited everyone to the CNO call on Thursday because Hilton's going to be diving into the census data. And I just thought it would be a good opportunity for y'all to have that information instead of trying to translate it after the fact. It's a 30-minute meeting, 12:30 to 1.
Thanks for the invite, Laura.
Yeah. Okay, and then
Good.
board meeting.
Yeah,
Three.
could I go ahead and get, it's not an item on the agenda, but if we could get the 2023 board meeting schedule approved by an official motion, that would put us in a good place for next year. It is exactly the same as this past year, just moving it forward a day. So that's keeping everything on the third Tuesday, except for the Saturday meeting in August.
Okay, I move we accept the board meeting schedule for 2023.
I
Great.
second.
Second, okay, great.
Fantastic. Thank you. I will send you all invitations.
If the meetings were in person, evening meetings, interesting, but dinner time.
Yeah.
We generally provide snacks. And the very accommodating conference room and free parking at UH unless it's otherwise located.
Like in Maui.
Never had it in Maui, but we could look at that.
It was good bumping into you last weekend.
I know that was fun. That was a nice surprise.
Who knows? Maybe this
I would-
year we can add a field trip again, since we haven't been able to do that due to COVID.
In 3 years.
Mhm.
I second that, Bree. I'm just kidding.
Tuesdays are clinical days for me, so I probably wouldn't travel on any Tuesdays.
So is this hybrid or all in person?
We've been doing hybrid even beforehand because Anne and
Yeah.
Arthur, so we'd probably, and then when Beth was on our board,
Mhm.
she oftentimes was traveling, so we'd continue to accommodate both.
Okay.
We do have challenges though when we have gone to locations. If it probably is fixed now because COVID has fixed like Zoom access everywhere, but it used to be that we would have to log in with our phones and like pass the phone around. It was very
Oh.
problematic. So we'd have to test our ability to have a nice meeting in another location, because I think it was pretty miserable for Anne and Arthur when they were trying to listen in.
Mhm.
We're Zoom professionals now.
Yeah.
Yeah.
A talent that nobody knew we actually needed.
Isn't that the truth?
Okay, so does that bring us to the end?
Mhm.
Ah.
All right, you guys, I actually love you. And I thank you for all your commitment and your careers that you've given and for giving right here. So on that note, the meeting is adjourned.
Thank
Thank
you.
you, Ann. Thank you all.
Aloha. Thank
Thank
you.
you
Aloha.
all.
Thank you.
Bye.
Bye, Laura.
Bye, Anne.
I got people at my house eating spaghetti. I gotta go there.
Oh, you better go get a dish with them.
Oh, I will, but I'm not the top of the hostess category right now. Okay, bye. Bye, Clem.
Bye, Clem.